I've mentioned this before, but I think a huge problem in medicine and orthopedics and physical therapy is this concept of low back pain being a diagnosis. And sometimes it's acute low back pain or subacute or chronic low back pain. But we're treating pain like the diagnosis and not as a symptom of whatever the root cause diagnosis is. And more recently, we've adopted kind of this idea that this huge cohort of people have non-specific low back pain, meaning it's not infectious disease, it's not a tumor, it's not a fracture, it maybe not even degenerative problems in the facet joints or the end plates or the discs. And some people go a little bit take a small step further and say it's mechanical non-specific low back pain or mechanical low back pain, but they really use that word very loosely. And obviously, I don't have everything right. I do concur that the low back is a complicated part of the body compared to other kind of joints that are just singular joints that move in less diverse directions. But I do think Rob McKenzie proposed an idea that most low back pain is due to mechanical problems. And there's discussion, of course, over exactly what anatomically is happening when we fix mechanical problems. But they're mechanical, meaning they are provoked by certain movements and positions, and by definition, resolve with certain movements and positions. So I was looking through some old journals the other day and I was skimming them. And I think I want to point out just a title and kind of a research article that really points to this problem we have in medicine of just being really vague with understanding what causes low back pain. And therefore, I think the research just kind of perpetuates this, because instead of really digging into, I think, even getting further into what are all these problems that people are reversing with left side glide or right flexion rotation or standing extension or supine flexion, what are all these clinicians doing mechanically that's altering the back, restoring signs, so making range of motion normal, making nerve tension normal, making strength normal, and obviously abolishing symptoms and getting people back to function. I think we want the smartest minds looking into these success stories and asking what they're doing differently than 90 to 95% of other clinicians who don't use repeated movement testing. But instead, I think a lot of research bandwidth is going to studies that aren't, in my mind, contributing to helping us better serve people with low back pain. Low back pain and depression a few years ago were ranked as the top disabilities in the world. So this really matters because low back pain affects so many people. And again, I would argue that it's very specific mechanical low back pain that can be fixed with a very specific movement that is plaguing the vast majority of those patients. There are those patients that have other things, of course, but that's not the majority of patients. So the title of this article was The Effectiveness of Superficial versus Deep Dry Needling or Acupuncture for Reducing Pain and Disability in Individuals with Spine-Related Painful Conditions, a Systematic Review with Meta-Analysis. So just in the title, we can see that they're comparing superficial, deep dry needling, and acupuncture on pain and disability. So another pet peeve of mine is that the research is focusing on pain and disability versus looking at reversing the disorder. And to me, reversing any disorder in a body is when the clinician and patient agree on the signs and symptoms pertinent or relevant to that disorder, and they are reversed. Hopefully, if we catch it early enough, to a full extent. So your nerve is going back to full extensibility, your strength is going back to full strength, your joint mobility is going back to full mobility. But in a smaller subset of people, especially when the problem has been there for years or decades and other things have set in, we may be looking for maximal return of those things and not necessarily getting back to full. We do our best, but you can't bring people back from the dead if things have already shifted so far that they're, to an extent, irreversible. But focusing on pain and disability, yes, we want people's pain to be abolished or reduced as maximally as possible. Yes, we want function to return as maximally as possible, but we need to be thinking of those as byproducts to actually reversing the disorder. We know that lots of things can change pain, and I don't think we should be spending a lot of our research energy on looking at things for pain because we have tried and true things for pain and people respond differently. Some people need creams or gels. Some people need prescription drugs. Some people need over-the-counter. Some people like heat or ice or gentle movement. And obviously now we've also added into the fray needling and acupuncture. And for some people, those are good too. But of course, you have to weigh the time and the energy and the cost for these things. A heat pack at home is a lot cheaper and a lot less time and energy on the patient's part than going to get dry needling. So in the title, that focus on pain and disability, I think clues me into the fact that this is not exactly a study that's going to provide a lot of value to me as a clinician. Secondly, it talks about it's in individuals with spine-related painful conditions. And their intent is probably to create a larger umbrella, of course. But again, you need to have studies that look on treatment X for diagnosis Y. And this doesn't have a diagnosis. It's just people with spine-related pain. And that can be for any number of things. If we go back to some possibilities, again, a person with a tumor in his low back is a very different person to me than a person with a mechanical problem in the low back that responds to standing flexion repeatedly. So in other branches of medicine, I don't see this conundrum as profoundly. I really see it more along the lines of, does X help for diagnosis Y? And diagnosis Y could be like atherosclerosis or insulin resistance or celiac disease or Crohn's disease, versus does it help on stomach pain, or does it help on heart tightness or chest tightness? And in orthopedics, we have this predilection for looking at things spine-related pain. And those are different people. And Ron Donaldson wrote a great book about this. He was an MD who was trained as an orthopedic surgeon who discovered Robert McKenzie's work and started implementing repeated movement testing, and found a lot of patients did not need, of course, surgery. They had mechanical problems that could be fixed with mechanical solutions. That is, very specific movements, 1 or 2 usually performed repeatedly, and a temporary reduction of the movements and positions that make the person worse. But he wrote a great book called Rapidly Reversible Low Back Pain, and he really makes the argument for what I'm discussing now, which is we need to be precise with our diagnosis and therefore study which treatment is pertinent for that specific diagnosis. Just like someone with chest pain, it could be from heart attack, it could be from a panic attack, it could be from a rib fracture. You would not say, we're going to test medicine A on chest pain, because you wouldn't know who you're getting. Are you getting the person who's having a heart attack? You're getting the person who's having indigestion or that fractured his rib? It's the same thing with low back pain. You're not going to apply medicine A for people who have tons of different types of root causes that are causing the pain in the low back. So at the end of the day, I think our research needs to be better. And I think when studies keep coming out, looking at what helps with pain, what helps with disability, not necessarily following people from the long term, seeing if they have a maintenance and prevention strategy to make sure that their problem and therefore their pain doesn't come back. And when we just group people together, low back pain. Well, yes, I said before, I believe the large cohort of those people with low back pain have mechanical problems, but a person who has a mechanical problem that responds to extension is very different than a person who has a mechanical problem that responds to side glide to the right or flexion. So they're still apples and oranges, even though they might all be mechanical.